I'm Dr. Pradeep Pandey, Senior Resident from Department of Clinical Immunology and Rheumatology. I will be presenting a case of juvenile dermatomyositis with refractory cutaneous manifestation. 8-year-old female child. First visit is in March 2023 with 4 months history of inflammatory polyarthritis, with 2 months history of proximal muscle weakness and 1 month history of erythematous rash involving ears, hands, and periorbital region. History of present illness. Patient gives history of symmetrical small plus large inflammatory polyarthritis. There is a history of proximal muscle weakness in the form of difficulty in squatting with progressive difficulty of muscle weakness with difficulty in raising the head above, raising the arm above the head. No history of any distal muscle weakness. There is no history of bulbar involvement. The patient give history of periorbital erythema with edema, and there's a maculopapular rash over the ear lobules, bilateral elbows, and posterior thigh region. And the lesions were ulcerated at the knee. On examination, general physical examination, vitals were stable, no pallor, icterus, cyanosis, clubbing, lymphadenopathy. And on musculosystemic examination, no any significant abnormality was found. Uh, uh, for the above complaints, patient had visited initially to local practitioner where she was given 0.5 mg per kg of steroids. Uh, so her muscle symptoms were slightly, arthritis symptoms were slightly better after coming to us. So on musculoskeletal examination, she had no tender or swollen joint count, but MMT8 was 68 by 80. And on skin examination, there was heliotrope rash, ulcerated goutrons on both knees, and maculopapular rash on both the earlobes, elbows, shoulders, and posterior aspect of thighs. There was subcutaneous nodule palpable on erythematous subcutaneous nodules were palpable on elbows and thighs. X-ray was done for the arms and thighs to look for evidence of calcinosis, but there was no evidence of calcinosis. This figure A and B showing the maculopapular erythematous lesion, which was ulcerated, and bilateral elbow had Gottron sign. Uh, Workup wise, her hemoglobin was 9.4 gram per deciliter, platelet by normal, muscle enzymes, SGOT and SGPT were more, 123 and 119. Her CPK was normal, urea creat was normal limit, LDH was 892. ANA and dsDNA done from outside were negative. MSA panel showed MDA5 positivity, and viral markers were non-reactive by ELISA. So final diagnosis was kept as juvenile dermatomyositis, MDA5 positive, with components of myositis, MMT8 68 by 80, cutaneous lesion, heliotropsin, and ulcerated goutrons, and inflammatory polyarthritis. So patient was started on prednisolone 1 mg per kg for her weight. 20 milligram was started with methotrexate 7.5 milligram per week, and along with photoprotection was advised, and physiotherapy was advised. After 1 month, when she came for follow-up in OPD, her lesions were in the healing stage, and muscle power was improved, and arthritis was better. Then later, again in June 2023, patient presented to us with a history of fever with pus discharge from the ulcerated goutrons on right knee, and there were new lesions on the palms. At this time, patient was on prednisolone 12.5 milligrams per day and methotrexate 12.5 milligrams per day. Keeping the suspicion of infection, patient was stopped methotrexate, and prednisolone was continued, and patient was started on oral antibiotics by which her pus discharge and infection was resolved, and methotrexate was restarted after 2 weeks. Uh, Simultaneously, these two figures showing this infected ulcerated gouton. Also, patient has new erythematous papular lesions over the palms, which is inverse gouton. So there is both component, increased risk of infection in the form of pus discharge from ulcerated goutons, and new skin lesions, inverse goutons. So steroid was hiked up, and methotrexate was stopped. Steroid hike 12.5 to 15 milligram, so as to cover the disease activity. Then after patient discharge, then she again presented presented in July. Second admission was in July 2023. This time patient was on Omnacotil 15 milligrams per day and methotrexate 15 milligram per week. This time she had multiple pus-filled lesions with high-grade fever, as shown in the figure. She had multiple side such lesions over the trunk and back. And the culture from the site had grown Staphylococcus aureus, which was sensitive to clindamycin. Patient was given this antibiotic. So timeline was first presentation in March 2023 with myositis, arthritis, and cutaneous manifestation started on 1 mg per kg steroid and methotrexate. Then patient was well in between. Then in June 2023, patient got infected, ulcerated gallstone and new skin lesions. So component of infection as well as disease activity there. Steroid was hiked up, methotrexate can't be given. Then again in July 2023, patient developed multiple site pus-filled lesion, for which again methotrexate has to be stopped and antibiotics was given. So so in this case there were major three challenges were there: refractory cutaneous lesions, recurrent infections, and chronic steroid toxicity. So keeping in mind of recurrent infection and steroid and disease activity, her immunoglobulin level were done to check for immunoglobulin deficiency. So there was isolated IgA deficiency, and other workup was other immunoglobulins were normal. So keeping what to next to give, patient can't be tapered on steroid because of recurrent disease active cutaneous manifestation, as well as she is getting recurrent various different types of infections. So IVIG therapy was planned for her, which will balance her both, so that next, so that we can plan second line of immunotherapy. So patient is given first dose of 400 mg per kg IVIG, and patient is planned for starting tofacitinib after next visit. Then take home messages. There could be three patterns in juvenile dermatomyositis. It could be monocyclic, polycyclic, or chronic persistent. And cutaneous manifestations are more refractory. Muscle involvement is less, is easily manageable. Always balance therapy and its toxicity. Thank you.